Thank you. I'll start off with a few questions, but you can see from these presentations, this is a very exciting time to be obese in the United States. And so if I can just challenge the panelists a little bit, let me start with Rena Wing. You had shown that this intense lifestyle intervention in participants who don't have to pay for it in randomized controlled trials has some prominent and powerful effects. But this is not probably so easily to introduce into the mainstream, except you showed at the end this one slide using apps. What do you think is the future then of providing lifestyle therapy in a cost-effective way? If you could just expand a little bit on that.
I think that's one of the directions we really need to go. I think we need to figure out how do we provide it cost effectively, and how do we provide it through probably the physicians' offices and places where these patients are going to be seen. We're quite happy with this use of apps. I don't think that's the only way to go. We have developed, as I say, mine was an internet program. We've developed a smartphone program where we're getting extremely good weight losses. So I think that we can, over time, develop ways where we're removing the therapist, because that's the expensive part of the treatment, but we're able to provide the treatment and the support that the patient needs.
What should somebody do today?
Well, I think there's a couple of things they can do. Number one, I think there are some commercial programs out there that are quite good. And so I would suggest that that be one thing you can look at. I think the commercial programs that have gone, the online commercial programs are not doing very well. And so, I mean, it's always sad to me that when you look at what people do to translate a behavioral program, they miss so much of the essence of it. So, for example, when CMS has tried to translate a lifestyle intervention and provide reimbursement for lifestyle intervention, which I'm thrilled that they're doing. However, the model that CMS proposed is a model that doesn't really make sense from what we know about behavior change. It's done by physicians, which I think most physicians would say they're not the right people to be doing it. It involves only a few sessions, which I would argue is not what we need. So I think the same thing, by the way, is true with these apps, that the commercial programs lose the essence of these programs. So I'm hoping that over time we can help both CMS and commercial programs do a better job of delivering effective, evidence-based behavioral programs. Long answer, sorry.
John, so, as physicians, we prescribe drugs for everything. You have a headache, you take a pain medication, you sneeze, you take an antibiotic. But obesity medications, which show, even though they're moderate, they do have clinically beneficial effects. People are not prescribing them, and patients are not taking them, and drug companies are going to stop making them if they don't become more profitable. Why are they not being prescribed and taken? And should the government step in? Should something else happen to help encourage that or not?
Yeah, I think the biggest issue is that the drugs that we have available now are either very expensive or they have unclear long-term benefits. So as an example, phentermine is very inexpensive, but it's not approved for long-term use. And frankly, if you thought about it a lot, you would think that maybe it's not a great idea to take this speed-like drug as your major focus in pharmacotherapy of obesity. The other agents have side effects, or they're very expensive, and usually they're not covered by insurance plans. And one thing that I had not fully thought through, but someone mentioned it earlier today, it's on the order of 1,000 obese patients per primary care provider in America. So literally, to do drug therapy, we would need to have every primary care doctor get up to speed and be comfortable with these kinds of therapies. There are a handful of integrated centers in the country where behavioral therapists like Rena, drug therapists like me, bariatricians are available in the same group to manage this kind of care. We are just not well positioned to deal with this right now.
And so, Rachel, so you showed the power of bariatric surgery, which is quite extraordinary, and the mechanisms really remain to be elucidated, but it's really to show that you can cause that kind of weight loss. Clearly something is happening. When we think of a chronic disease model in other diseases like inflammatory bowel disease, surgery is used as part of the treatment algorithm. Early on, if someone's not responding well, you go to surgical therapy. It seems here when you mentioned 0.8 8% of people eligible for surgery actually get the operation. How should this come into the more mainstream of therapy, and can society even handle it? You know, are there enough surgeons, and are there enough, you know, is there ability to really provide that kind of therapy if it becomes more popular?
So firstly, I think not enough people are aware of the benefits of bariatric surgery at the physician level or even at the patient level. I think there's still this kind of overhang that it's very risky and that it is high risk in terms of length of stay, whereas most patients only stay 1 or 2 nights. So I think one of the first things is education and access to it. And there are some new guidelines. So for example, the Diabetes Surgery Summit is basically, and in the UK we have different guidelines that anybody with type 2 diabetes with a BMI of 35 has an expedited referral for assessment for bariatric surgery. So we know that remission from type 2 diabetes and the durability of the remission is much better the closer you are to diagnosis. So actually, it's the folk that have just been diagnosed with diabetes, who have their beta cell mass, that we should be offering bariatric surgery to, because they have the most to gain. But it's really sort of getting that across. And it's a bit of a field change. Most people think, well, you must be able to do it through diet and exercise and pharmacotherapy. Whereas we have a really effective treatment that we know saves money. And it's really trying to get that sort of the data out there and the mind sort of change.
I think the other thing that's happened in the United States is that bariatric surgery, when it first came out, was not medical therapy. It was really cosmetic therapy. And that was the entire focus of the bariatric surgery community, and frankly, most of the people who refer to them. I don't think people in the United States have fully embraced the idea that this is really, you know, an important medical intervention. It happens to be done in a surgical suite, but the aims are largely to achieve medical aims that can't, you know, that we frankly are not very good at achieving otherwise.
So I just have one more question, then we'll open it up to the audience. So Bill Dietz touched on this morning. That's the problem of obesity in children, which is the saddest part of obesity, because an obese child will become an obese adult, and their form of obesity is much more severe because they've had it for so many more years. So I wonder if we can just discuss among the panel, what should we do, behavioral therapy, drug therapy, and surgical therapy for children and adolescents in terms of trying to manage this critical issue in children?
So I'll begin, and then each person could comment. Okay.
But be quick.
I'll be real quick. So Len Epstein did a series of studies with children age 8 to 12, showing that behavioral treatments can be very effective long-term through 10 years. I think each age group needs different types of intervention, though. Adolescents need their parents not so involved as children, but I think we can work well with children, perhaps better than with adults.
The drug therapy has largely not been studied in children. I think there's tremendous reluctance on the part of pediatricians to prescribe them. Only in the most specialized centers do they even consider that kind of work. I don't personally treat children, so I don't have a personal experience with it, but I think that's where it stands. But you guys have a little bit more experience.
So the Teen Lab study was published in the New England Journal in January of this year, looking at 200 plus adolescents who underwent bariatric surgery, and again showed marked improvement in cardiometabolic health. There is, however, the risk of the nutritional deficiencies, and we don't know what the long-term risks of that is going to be. So at the moment, bariatric surgery in adolescents is for the 14-year-old, 15-year-old who pitches up in a wheelchair weighing 300 pounds. So at the moment, we're doing the sort of extreme end, but exactly where bariatric surgery fits in that place, I'm not sure anybody really knows, but we know it can bring benefits, but the concern is what are the later health implications of doing that?
And just to add again, but you know, I think the biggest issue among children is that so many of the kids that are most disproportionately affected with obesity and particularly with diabetes are socioeconomically terribly disadvantaged, and having access to any of what we're talking about in general, it just is not available to them.
Shall we open up to questions from the audience? Please go to the microphone, state who you are.
As people are gathering, I'll just mention one other thing too, which is that pediatricians often don't refer children for obesity until they're severely obese. They don't catch the child who's somewhat overweight or gaining rapidly and send them for treatment, and that's who we should be treating.
Dr. Adherence, I'm Les Bennett from UCSF. I'm a pharmacologist on bariatric surgery, but I read a recent European paper that said sleep versus Roux-en-Y in terms of weight loss was the same, but the outcome was better, the long-term outcome was better for the Roux-en-Y. Now, first of all, maybe I've got it wrong, but I would suspect that says, I would suspect no difference in behavior of those two groups of people. So it would say removing the gut is really important, and we don't understand that?
So the data we have comparing sleeve and bypass is relatively little. The biggest RCTs are only 200 per group and not really powered in particular to pick up differences in patients with type 2 diabetes. So I think to say that they're comparable at the moment is probably a little bit premature, and I think we need the bigger data. And the other thing is they do very different things to the gut. And I think that we probably will be able to do a precision medicine-based approach using what is the driver in that person, looking at their biology and their gut hormone profile, and then selecting either surgery, which type of surgery, or no surgery at all, depending.
Thanks. My name is Sue Curry. I'm Dean of the College of Public Health at the University of Iowa. I actually have a couple of comments or observations. The first one, and it speaks to what Rena was saying about weight maintenance and weight gain prevention. And so when I look at your picture of the person who lost 25% of their weight with bariatric surgery, where in the trajectory of their weight gain could we have intervened and not tried to get that person to lose weight, but to maintain the weight? And that's really, I think, something that we need to hear about in addition to all of these wonderful opportunities. And then the second piece relates to what I think is an unreasonably high bar for behavioral counseling. We never talk about, delivering cost-effective post-MI rehabilitation or physical therapy, or having people come in for multiple sessions after they have had, a compromising health event. And yet, when we have a multiple session intervention that works, better than medications in head-to-head trials and so forth, suddenly we have to take professionals out of the picture, and we have to deliver them, in the most cost-effective way, even if it compromises their effectiveness. So I just want to put those 2 points out for consideration.
Thank you. Dr. Povian?
I probably have more of a comment too. Caroline Povian, representing the Obesity Society, but I am the director of a weight management center at Boston Medical Center, which is the largest safety net hospital in New England. We see thousands of patients a month with obesity, and as you know, it's still considered a second-class disease, even though we're here gathered together. The AMA proclaimed it to be a disease in 2013, yet despite that, the only recourse I have, besides lifestyle and bariatric surgery, which is covered for those people in the middle who need something more, we have phentermine, because it's $11 a month in all 3 of our pharmacies associated with the hospital. The other medications that were mentioned, there are 6 of them, 5 of them, in addition to phentermine, are extremely expensive, as you know, and not covered by Medicare, Medicaid. Some of the private insurers are starting to cover those medications. So can we call this discrimination? Because, the largest body of people in the United States who are suffering from extreme obesity are lower socioeconomic status. They can't afford these medications. We're starting to get them covered by private payers. What are your thoughts on that? And how can we do something about it?
So let me add that, Ness. We'll address it to John Buse, because he was president of ADA, so he's politically very knowledgeable. So, obesity has not come up in any of the presidential debates, which is the biggest public health problem in this country. And there's a Health Care Act that's been on the books for over a year now, the obesity, access to health care, that nothing has happened with it. What needs to be done on Capitol Hill to really help support therapy for obese patients?
Something needs to be done. I am not nearly smart enough to come up with the what needs to be done. But I think in general we have a system that is completely illogical in every way. the point that I was trying to make is we've evolved in the diabetes field a lot over the last 2 decades with better evidence and better coverage. We used to not have any coverage for dietitian services or education 15 or so years ago. I think there is a future in obesity. It clearly isn't here now, but hopefully organizations like the National Academy of Medicine can help it move forward. It is insanity out there. I mean, the decisions that we make as a society, from the stuff that we talked about this morning, that was talked about this morning with advertising, et cetera, and what's being discussed now with regards to coverage decisions, it's ludicrous.
Michelle Carnell, University of Florida. I would like to disagree. I do think that it was brought up in the presidential election with the GOP nominee referring to women as fat pigs and calling them Miss Piggy.
I stand corrected, thank you.
But my question was for Dr. Wing, and you talked a lot about how adherence is the most important predictor in any sort of trial. What are the predictors of adherence, and are there any effective strategies or interventions to improve adherence in our patient populations?
Well, first of all, I don't think we really know what are the predictors of adherence. I think there's efforts to look at whether genetics could predict adherence, whether some of the biological variables could predict adherence, but we don't know yet. As I say, you can do this very short, you can tell right away whether a person's going to be adherent or not, and that seems to be the best test that I have. And what was your other question?
Actually, could I just add to that?
Yeah.
And it also works with the drugs.
Yes.
I mean,
Yes.
you will pretty much know in 4 weeks whether someone's going to lose weight with a drug approach as well.
The same is true with bariatric surgery. You can tell at 12 weeks usually how somebody's going to do. So I would argue it's the biological response to the weight loss that is going to be your predictor of how you're going to do.
My other question was, is there anything that we can do to improve adherence? You just stated it
That is what
physiological.
That is what all behavioral techniques are designed to do. They're designed to help try to improve adherence by educating, helping the person change their environment to make it easier to adhere to the behaviors, helping them see the reinforcing value of making these changes. But it's not perfect yet.
But community support, making sure that there are not co-payments for important medical, and behavioral interventions. I mean, there's a lot of things we could do to improve adherence.
From a bariatric surgery point of view, I think those people who aren't doing well, we need to pick up early, because those are the people who need the extra support. And we've already invested, but actually then a little bit more investment in terms of psychological, lifestyle, exercise, we know can make a difference. So really picking up the people who aren't doing so well initially, I think is really key to actually getting the maximum benefits.
Same in behavioral.
Thank you.
My name is Bill Hazard. I'm from Wake Forest University, and I'm a gerontologist. Always have been mostly interested in prevention, meaning that starts in utero and it ends after death. And that's the study of the aging process. And I haven't heard that really addressed from that perspective. It interests me, reactive. And I'm also mostly interested in gender issues. And I think we're tiptoeing up forward one of them, which may be political, because I think it's different for women than it is for men. And I think we should think about that. But as I look at the big picture, it's starting very early. How can we educate the primary caregivers? How can we mandate that everybody learns this is a public health problem? Hopefully we'll hear about that later in the day. But I'd like your opinions on the issues of differential sensitivities by gender and also at different stages across the lifespan.
Well, I'll take the across the lifespan a minute. I guess one point I would like to make is that we often say, well, treatment isn't working so well, so let's do prevention, as if prevention is going to be so easy. And I just want to caution everybody that prevention is going to be equally difficult, that it's very hard to prevent obesity or prevent weight gain. Those of us who've tried it have had difficulties with that area. I'll leave the gender one for you all. What was the other?
Let me challenge the panel, which it touches off on your question here. Is weight loss and BMI, should that really be the goal? Because what this question really addresses, in the older adult, losing weight to become more functional, it becomes much more critical than in a younger adult. The weight you can carry when you're young is unable to be carried when you're older, and you end up getting admitted to a chronic care facility. So we focus on body weight, but we're not looking at the big picture, the whole patient. So if someone loses 2% of their weight, but you've reduced their blood pressure, improved their lipids, is that not a successful outcome? And if they lose 10%, but you haven't changed any of their comorbidities, is that not a failure? So, Rachel, you're nodding your head, so
well, it depends where you're starting from.
Yeah.
So if you're starting off at 330 pounds, then losing 2% isn't really going to touch the sides. So it really depends on your starting point.
Mm-hmm.
Can I just answer his question?
Oh yeah, go ahead, yeah. Yes.
So in terms of looking at people with a BMI over 40, then it is higher in women, both in the US and the UK, than it is in men. So it's about 8% of US women have got severe obesity compared to 5% of US men, and that differential is increasing. And when we look at people coming for bariatric surgery, then again it's 70% are female. And in part that is driven a little bit by the stigma of being obese, which is greater for women than it is for men. So there is a gender issue, both in terms of becoming severely obese and then also presenting for treatment. I think the one that sort of goes against that is probably France. And I think for some reason French men are more bothered by their appearance, because in France it's almost 50-50 in terms of men and women for bariatric surgery.
Thank you. It's complicated.
Okay, next question.
Robert Ratner from the American Diabetes Association. When you begin to speak with people who have dealt with obesity for a long period of time, no one has problems losing weight. They've done it thousands of times. The difficulty is the weight regain. So a question for the panel: what do we know about what the body weight set point is, and how do we change it?
So I don't think we know enough about exactly the body weight set point, and we don't know it at different BMIs. So there's very little data saying, well, what happens if you lose weight with a BMI of 27 versus if you do it when you're 40? And can you shift it? And one of the sort of most fascinating things about bariatric surgery is even when somebody has lost weight, been at a normal weight for 10 years, if we reverse the surgery because of other reasons, they put all of the weight back on. So even though they've been at a normal weight for 10 years, whatever it is that drove their obesity has not yet reverted, because if we reverse the plumbing, then the diabetes comes back and the weight comes back. So I think that tells us that it's a chronic problem, that any drug that we're going to use for weight loss maintenance is going to have to be lifelong.
And just to add, it's exactly the same with the drug therapies. I mean, we have very successful individuals who lose a remarkable amount of weight with combined behavioral therapy and drug therapy, and they just lose the ability to pay for the stuff, or we can't get it for free, or their insurance plan changes, and they come off the medication. It's just remarkable how fast the weight comes back on.
So this is all biology.
I suspect it is, and I think everybody who's overweight has had this experience of, they have their weight that they gravitate towards, and they can struggle away from that.
Well, what do you mean by biology? Yeah, because everything is essentially chemicals in the brain. But Ashley Gearhart this morning, this pleasure and joy of life, that the things that made you obese in the first place are all still there, the environment and those pleasure systems. So
exactly
what about
what I was going to say. That the behaviors very much come back too. I mean, if you watch somebody, they will say, I went through a period of stress, and I no longer could focus on getting my physical activity, so I stopped being being active. So they change their behaviors back to what they used to do, and that's the other reason. I'm not saying biology isn't a factor, but behavior and the environment is too.
Well, mentioning biology, this is a two-part question. The first is there are certain genetic syndromes, most notably Prader-Willi syndrome, where one sees massive obesity. And I wondered whether or not bariatric surgery had been done in any of these subjects, because it would help to understand the feedback mechanism. And the second part of the question is, there are several mutant mouse models of obesity, and whether or not there have been any animal models to look at the bariatric surgery in an animal model.
So I'll answer the first part first. So Prader-Willi doesn't respond well to gastric bypass. However, there are data suggesting that sleeve gastrectomy, which is removing the stomach and ghrelin, which is implicated in Prader-Willi, does work in a subset of patients. And there's also a mouse model of Prader-Willi, which again responds very well to sleeve gastrectomy. So there is some evidence that potentially for Prader-Willi, then sleeve gastrectomy is an option. But for the majority of syndromic obesity syndromes, then if the hypothalamus is affected by the syndrome, then often these patients don't respond well to bariatric surgery because that's in part how the surgery is working, through signaling through the hypothalamus. So we're very careful with patients who've had craniopharyngiomas, who've got hypothalamic obesity, because often they don't respond well. To come back to your other question, there are lots of mouse models now of bariatric surgery, different types, coupling it with genetics. But mice are very different from man. They have a very different stomach. It has a top part that's keratinized epithelium, and also the way that they regulate their energy expenditure is very different. So it's useful for getting some insights, but doesn't necessarily translate into what happens when you go to higher sort of animals. And often mini pigs, I think probably at the moment, are probably one of the best models of what might happen, but you can't couple that with the genetics. Mm-hmm. So mouse models can be useful, but with a caveat that they're not man or woman.
Barbara?
Hi, my name is Karen Gillespie.
Oh, Karen, sorry.
I'm with Novo Nordisk Public Policy Team, and just wanted to share a comment that actually there are some promising virtual models of intensive behavioral counseling. Omada Health, for example, has done some studies that show very promising results with a virtual program. And then also wanted to share that the pending Medicare coverage of the diabetes prevention program is actually based on the WISE program. So it actually is based on repeated contact over a period of time, and it was able to show a savings of over $2,500 over 15 months. So there's a lot out there in the community that can augment what physicians are doing in their offices.
Totally agree. Those are wonderful programs.
Thank you.
Okay, Judy Stern, University of California, Davis. I have one disclaimer. I'm not a surgeon. But I would like to propose that maybe what we should do with obesity treatment is do surgery on everybody. And we know they'll lose weight. I know you're shaking your head. Let's discuss it. And there are side effects associated with, but obesity kills. So I think it's really imperative that we figure out how to assess this to find out what works. And I'd start with surgery.
Maybe I would just comment that, I mostly take care of people with diabetes, and I have many patients who are not doing particularly well with their diabetes management program, and I am quite desperate for them to have surgery because, frankly, I just am at a loss as to what else to do for them. And I would say the more I want someone to have surgery, the less likely it is that they are willing to have surgery. It's the thing I understand least about my practice now. So even though what Rachel says sounds very appealing, it is remarkable how few people who have major medical consequences of their obesity are willing to even consider it.
But Rena will tell you how to do it. I mean, she's really, no, but this is a compliment. She's superb.
What? We'll tell you what? Oh, how to do it?
She can work with you.
For a fee, yes.
But before, and
so Andy Goldberg, University of Maryland. I have one statement and a question. The statement is, as a geriatrician, and I got up after Bill Hazard because he was my mentor, I'm very concerned about the statement that exercise is good for maintaining your weight, because as I've aged, when you lose weight, 1/3 of the pounds you lose is muscle. And that puts you at risk for sarcopenia and falls, which is a devastating problem in the aging population and the society which we live in. So that I have a concern that we look at the need for resistive exercise, weight type exercise, maintaining muscle mass, and providing the critical essential amino acids for muscle synthesis when we put people on diets and we operate on them because of the dangers of falls and injury related to sarcopenia. Classic work by John Hollisley clearly showed that caloric restriction is effective, but you lose a third of your muscle mass. For every pound, you lose 0.3 pounds. It's only when exercise is added that you protect your muscles. The other question that I raise is we did not replace cigarettes adequately. With the cessation of cigarette smoking, obesity probably, I have not looked at the data, but the weight gain associated with cessation of cigarettes is enormous. It's in 2 months, people gain 20 pounds. So that we haven't substituted adequately for that change in our society, and I think we should be offering careful attention to methods by which that population can be adequately treated with another addictive substance that could perhaps be attractive to the drug industry, that could perhaps provide those signals that would perhaps one of the mechanisms for smoking cessation, that smoking causes obesity, is leptin resistance, so that things that would affect leptin might be one way to look.
Thank you. No comment needed. We're over time, but you've been so patient. 3 quick questions and quick responses if necessary.
Okay, Eva Feldman, I'm a neurologist from the University of Michigan. Very quick question. We've been talking about individual weight loss, and my question is because frequently families are obese rather than just individuals. If, for example, a primary caretaker such as the mother or wife undergoes bariatric surgery, is there a change then in the whole family in terms of obesity, or if so, or any other intervention that causes one person to lose weight?
Well, in the behavioral literature, there's certainly been evidence that if one spouse loses weight, the other person will lose weight. And I think, Rachel, you have some data with parents and children.
Yeah, no, so again, if usually the mum has bariatric surgery, then the children do tend to lose weight, and often the dad will come back and want to have surgery. Otherwise, he's worried about losing his wife. So there tends to be a kind of knock-on effect. But there are published data showing that if a parent has bariatric surgery, then the children actually tend to lose weight because it does engender a complete change in food in the household.
Thank you.
Susan Stone. I'm a certified nurse midwife from Frontier Nursing University, and it's been mentioned several times how the women are heavier than the men by not a large percentage, but how much of that is attributable to the pregnancies and retaining? Is most of that, do we know that most of that's because of the pregnancies? So if we worked harder during the pregnancies, we might not see that?
So most of the women who I see have been normal-ish weight as adolescents, and most of their weight gain relates to pregnancies or even failed pregnancies. So miscarriages that don't get dealt with, that then they get told to go off and get pregnant again, and psychological issues that haven't been resolved. So I think actually taking care of people when they have events in their life and also during pregnancy, I think is a key opportunity that we could really target.
I suspected as much. Thank you.
Dr. Khan, you have the final word.
Final question, anyway. Ron Khan, Boston. A really nice panel discussion, and I want to sort of ask a question almost about health policy, which is when we compare surgery to medical treatment of obesity, we accept different standards. That is to say, we accept 1 in 500 or 1 in 1,000 people will die of surgery. We would never accept 1 in 500 or 1 in 1,000 people dying of medical therapy. And I wonder how we can compare these types of therapeutic choices and interventions when we hold one to one kind of a standard and one to another. And is there a way to get around this, or should we get around this?
Well, that was one of the points that I was trying to raise in my presentation, and we spoke about it before this session. It's just a regulatory quirk that devices are regulated in a completely different way with a completely different set of standards by a completely different group of individuals in the United States than drugs. And what you describe is in fact true and is a direct consequence of that. We have an FDA commissioner that's very interested in diabetes and its consequence, cardiovascular disease, and perhaps we can get some alignment in the future, but for now, that's just the way it is.
But Rachel has shown the patients who are getting surgery, and the data are not great, but they are supportive. These are very sick people who actually, it increases survival. So even though the mortality of surgery might be 1 in 500 or 1 in 1,000 or 1 in 200, survival is actually improved. If they didn't have the surgery, they would be dying sooner after the perioperative period.
You also argue that for effective drugs as well. So if you had effective drugs that cause that, then what is the trade-off that we'd be happy to accept?
And some of the drugs in the pipeline are remarkably effective in mice.
We've cured obesity in mice pretty well.
Say, if we could just
anyway,
mice.
We're out of time. Let me thank the panel for an outstanding job and the audience for great questions.